Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
So what we want to try to do is, it doesn't always happen that way, but when you're doing implants, at least the idea is you would like to have the implant process restoratively driven. So what you'd like to do with a good set of mounted study models is figure out what you'd like your final restoration to look like. Whatever I'm going to do, what would I like my final restoration to look like? And then, if you will, reverse engineer it or work backwards. So that the idea is when the implant is placed, it's in just the right spot to suit your restorative needs. So that you've been thinking about the final restoration before you start sinking holes for the implant. Because not infrequently, we see implants that have been placed and either the location or the angulation or the occlusocervical height is such that it really handcuffs our hands behind our backs in terms of the restorative process we're able to undergo. And it makes a lot of the restorations extremely challenging to do. And let's say historically, if you go back historically when implants have been placed, a lot of the times many general practitioners don't want to be that involved with the planning of the implant. They just tell their surgery colleague, whether it's an oral surgeon or a periodontal surgeon, whatever system you like, just give me the implant, and oh, by the way, would you take the impression for me too? So what's left for you to do? I mean, like, seat the crown and charge $2,300. That's good work if you can get it. But I guess my question would be, is your patient getting good value for the dollar they're spending to pay you to do this thing? My argument would be no. And so if we look at a case that we had in clinic not that long ago, which was a Panorex taken, and what very often people will do if they're not going to make any kind of a surgical guide and they're going to go ahead and just sort of freehand the implant at the time of surgery, what you see is basically on screen left, you see an implant, and the long axis of the implant is pretty good, and it seems to be paralleling the long axis of the tooth. Now, sometimes the thing that can throw you off is if you don't have a good PA X-ray and you're only going by the angulation of the clinical crown. Anytime there's a crown on a tooth, or especially if it's a post-core end crown, you can't always count on the long axis of the crown that you see in the mouth being in the long axis of the root of the tooth. Because when the crown was done, they may have morphed it or tipped it a little bit one way or the other, which in fact happened in this case. And so if one were just looking at the clinical crown on the tooth, one could argue that if the clinician was trying to line this up with the clinical crown as they saw it, they didn't do too bad a job of lining it up with the clinical crown, but oops, the clinical crown wasn't in the long axis of the root. So that can lead to complications at times. And so in some of these situations, and I've seen more than a few of these, the implant doesn't quite touch the root of the tooth. That is the natural tooth that's adjacent to the implant. The implant doesn't quite touch it, but it sure isn't for lack of trying, because it sure tried to get in there and touch it. So over time, if you get one that, depending on your radiographic angulation, you may have one of these teeth over time that the natural tooth adjacent to your implant starts to have problems because it got nicked with the placement of the implant. And that's not a difficult situation to avoid with just a modicum, just a little bit of pre-surgical planning. So this is basically the wife of a dental student that graduated a few years ago that was part of a study that we did. And what she had was a retained primary molar. So what we did is we replaced the retained primary molar. I don't have pre-extraction pictures of it, but it was one of those where the root was essentially entirely resorbed and all you had was the epithelial attachment holding the clinical crown in. So that was taken out, we let it heal up for a little bit, and then here was our final restoration on this. And the reason that this crown doesn't look quite like a molar is it's in the position of a retained primary molar. So it's a little wider than a bicuspid and a little narrower than a molar. But the point that I want to try to make is, if you go ahead and line your implant up so your implant is lined up fairly correctly, what we see is the real nice thing about it is that the soft tissue just happens. You don't need to come back and do extra grafting procedures or extra periodontal procedures to get a good aesthetic outcome, pardon me. Because if your implant is placed correctly and you've got adequate interproximal bone between the neck of your implant and the root surface or the CEJ of the adjacent teeth, if these spaces are about right, lo and behold, your soft tissue just happens and you get pretty knife edge looking papilla and it comes out nice for you. And again, none of this stuff is rocket science. It just takes a little bit of pre-surgical planning. So what do we do if we're going to set these things up for a molar? Now, one of the things you want to look at in your pre-surgical planning is many times you want to look at the buccal lingual width of the crest of the ridge. So many times if you look at a PA X-ray or a Panorex X-ray, you may see some situations in which the mandible looks real tall. So looked at from the side, you see a lot of bony height. But the other thing that is equally as important is look at what the width is at the crest of the ridge. Because remember that what you want to have is whatever the diameter of your implant is, you want at least 1.5 millimeters of bone to the buccal and lingual of your implant. Usually there's going to be plenty of bone mesiodistally. The question is, do we have plenty of ridge width labiolingually or buccolingually? So if you need 1.5, it's even nicer to have 2 millimeters of bone to the labial and lingual of your implant. So whatever the diameter of your implant is, you need 1.5 to 2 millimeters of bone at the buccal, 1.5 to 2 millimeters of bone at the lingual. Now then you've got to allow also for some thickness of soft tissue. So if you were to sound this bone, and we don't routinely do that here, what do we mean by sounding bone? If you were to anesthetize this individual, and so that their buccal vestibule and the mucosa is anesthetized, and it's also anesthetized across the ridge and on the lingual, you literally take a perioprobe and you just go crunch and you stick it right through the gums until you bang into the bone. And you measure the thickness of the soft tissue. And they call that sounding the bone. If you want to be a little kinder about it, you could take an endostop and maybe put it on a 30 gauge needle and carefully just push the 30 gauge needle in. It pushes the endostop back on the needle. Okay, and you measure how far is the endostop from the tip of the needle. And so typically if a person were to sound the bone, you'd usually do it in 2 or 3 positions on the labial or the buccal, sort of near the crest of the ridge, halfway down the proposed implant placement, and about 10 to 12 millimeters below the crest of the ridge, because if your implants are 10 to 12 millimeters long, what's the thickness of the soft tissue? Sort of near the crest, 4 to 6 millimeters down, and 10 to 12 millimeters down. Then the same thing over the crest of the ridge, and you could do the same thing on the lingual. So you'd have some sense of, okay, how thick is the soft tissue? So then if you're looking at the width of a ridge as you would see it on a cast, on a gel trait impression that you took and poured up, then you're thinking, what I need for my buccal lingual width here is the diameter of the implant plus 1.5 to 2 millimeters, both buccal and lingual for thickness of bone, plus the thickness of the soft tissue. And very commonly, soft tissue is about 1.5 millimeters thick. And so those are just things that you want to think about during your planning procedure. If you take a PA radiograph as part of your planning, so when you're back in the lab and you're making a radiographic guide, it's real helpful to have a good PA X-ray of the area in question so you can see where is it that I want to place my implant and what is the angulation of the roots of the teeth on either side of the empty space. Now in some situations, if you have an empty space in which you've got one of these tilted molars that we see sometimes. So you've got a bicuspid that's got a pretty good long axis angle, and you got a bicuspid, pretty good long axis angle, and then back here somewhere is a molar that's got like this angle tilted way at the back. When you're planning implants in here, it's not that you have to split the difference always. If this is obviously tilted forward a little bit, if you're planning an implant in here, you'd want to plan to be in the long axis of the teeth that haven't been tilted. People follow that okay? So many times we'll say if it's near the anterior part of the mouth, okay, and we don't typically do that in the undergraduate program, but if you were planning for an anterior implant and you saw roots, adjacent roots converging, you're trying to do the best you possibly can to split the difference. So down at the apex of your implant, you're not bumping into either of the two tooth roots, because if they converge a little bit, that gets trickier. If you've got the roots are parallel, staying parallel between the two is pretty easy. If you've got one of these in the posterior mandible in which the teeth in the anterior part of the arch are pretty much straight up and down, some of the posterior teeth are tilted forward, don't feel that it's mandatory that you split the difference between these angles. Keep it in line with the teeth anterior to it that have a normal alignment in the arch. So we take a look at what is our angulation. So then we switch over, and here's some of the models similar to what you used in your preclinical exercises. So what we want to do is take a nice alginate impression of our patient, and then we sort of look at an area where we're going to do the implant. We've drawn some lines on here. What we're going to do typically is mesiodistally. You're going to estimate what the center space is. That is mesiodistally, what's the center of that empty space. And then from buccal to lingual, either you take some measurements or you look at the proximal surface of the adjacent tooth anterior to the space and look at the proximal surface of the tooth posterior to the space and see what's the midpoint of the proximal surface of that tooth, what's the midpoint of the proximal surface of that tooth. Make your cross hatches and then double check with measurements to see, am I far enough from the labial or buccal aspect of the ridge so that I've got enough thickness of tissue here. Now what can happen nowadays, in the old days before we had very predictable guided bone regeneration, if you were a little bit too close to the buccal and you had dehiscence, so when the flap got laid and the implant put in, if part of the implant poked through the bone at the buccal, that's sort of a problem. But nowadays we've got lots of materials with which they can do guided bone regeneration, Pyros, BioOs, semipermeable membranes, lots of other things that they can put on here so that if there happens to be dehiscence at the buccal or labial of where your implant's placed, they can fix that. They can cover that up with bone, and if it's been grafted, what you're going to typically want to do is withhold putting the final restoration on this for 6 months. So it gives your graft time to heal real well. But what you're trying to do in your planning is make as sure as you can that you keep your implant within the confines of bone, buccal, lingually, and not banging into the roots of the teeth mesially or distally. What I'll typically do if I'm holding hypothetically a radiograph, so as I've got this cast oriented on a surveyor table or just holding it in my hand, I typically make one dot in what I'm guessing to be about the center mass on the tooth crown. Same here. And then dropping down, again, imagine if you were doing this on a clinical case, as you're looking at this cast, right beside it in the lab, you've got the PA x-ray of that same edentulous space. So when you're drawing those two lines on there, you've got your PA x-ray right up next to you so you can see that you're making your lines pretty much in the direction you want them to go. So we go ahead, we make our lines, we split the difference with our surveyor, we've got things lined up here, and then we want to look basically, where do we want things buccolingually? So if we line and orient our cast on the surveyor table so that we're in the center of the proximal surface of the tooth at the mesial and distal, and then go ahead and make our X marks the spot, we're going to make a little dimple right in the center of that aspect, and that's where we'd like our implant to come out. Then we go ahead, make a radiographic guide, and take an X-ray. So when we make a radiographic guide and take a PA X-ray, what are we going to see? We're going to see that little 10 millimeter radiopaque silhouette that shows up as part of our X-ray guide. So the thing we want to see with that PA X-ray is the length of our little radiopaque silhouette and the full length of the teeth on either side. And what I then do is just check out that little set of burr blanks that you've got, take the 2 millimeter drill itself because it's longer, and I superimpose it right on top of that radiopaque silhouette. I superimpose it right on top so I can see what the projection of that is as it goes up between the roots of the teeth. So before you've ever even made your surgical guides, you can see if the angulation that you have set up on your surveyor table is in fact correct. So the whole thing about making a radiographic guide is just ahead of time, can I see that I've got things lined up so that our alignment's going to be real good. Assuming you would even ever want to do any of this stuff to yourselves, basically, and it's in your notes, there's this tool and die company that sells stuff, lots of machining parts in Ohio. And basically it's McMaster-Carr, www.mcmastercarr is their URL. And then when you go through their catalog or the front page of their website, they've got drill bits down here. And if you go under their drill bits, you can order drill bits in 1/10 millimeter increments in metric sizes. And for each size of a drill bit, you can also order a drill blank, a high-speed steel, smooth-sided piece of steel that they used to make drill bits out of. So regardless of the implant system you would use or you would use in conjunction with your surgeon, you can find the appropriate drill bits from this website. And so what you've got basically is some drill bits and a blank. So there's different sizes of a drill bit and a blank, you know. So this would be the 2 millimeter one used for the radiographic guides. And then for the system we happen to use here, that'd be 2.2, 2.8, 3.5, and there's one size bigger than this, 4.2. But those are all available pretty easily. So there's another company called Small Parts Incorporated, and from the Small Parts Incorporated company you get the little 10 millimeter stainless steel dowels. So the reason I go to them is from the company that sells me the drills and the drill bits, I can't get a piece of 10 millimeter long stainless steel from that same company. So from the Small Parts Incorporated, this is one of their most recent catalogs. They got phone numbers and websites. These little 10 millimeter long stainless steel dowels are $21 a hundred, 21 cents a piece. So they're not particularly expensive. And this is what they look like. You order a package of 100, that's $21 worth of them, and that'll last you your entire practicing life. So we make a radiographic guide. We go ahead and take our picture. And let's say for the sake of discussion on this one, if we were to look at that picture and then go ahead and superimpose the drill on it, if we say, gee, if I superimpose the drill so it hides that silhouette completely, for the sake of argument, it's not perfectly centered. It's a little bit toward that bicuspid root. I'd like the implant to exit the crest of the ridge at the same place, but I'd like the apex of the implant to be just a little bit further toward that molar. So if you happen to take a radiograph with your radiographic guide, and it comes out and you say, darn it, I need to re-angle this just a little bit and take another picture. How do I determine how much do I want to change the angle? If you go ahead and just have your drill blank superimposed on this and then pick either end, you just either pick this end or this end and move the apex of this over so that now the end of your burr blank is, as far as you're concerned, centered, dead center between the two roots. And over a 10 millimeter length, how much of the silhouette of my little dowel showed up? So I'm guessing that's about half the diameter of the dowel. So that's about how much I want to reorient things. So that little bit of dowel that's uncovered, that's the amount that I want to re-angle. So what do? We very quickly, while the patient's in the chair, we go back to the lab, we just take an instrument and we push that 10 millimeter dowel out of our radiographic guide. When we've pushed it out, now we're just going to take an acrylic burr and very quickly we're just going to gut this thing. But before we gut it, we want to go ahead and change our angulation to the new angulation for our radiograph. So when we put this guy back on our surveyor table, we haven't changed anything yet. So if we put an analyzing rod on the surveyor, we can see that there's no daylight whatsoever between the analyzing rod and what I did when I pushed this little 10 millimeter dowel out. What I put in it was one of the little longer drill blanks that I used to make this in the first place. So push the 10 millimeter dowel out, push one of the blanks into the top of this, leaving it standing up tall like a radio antenna. So here's my blank sticking up out of my radiographic guide. Here's an analyzing rod, so I can see there's no daylight between those two. Now I want to go ahead and tilt my surveyor so that the amount of space I've got, or that angle, between my analyzing rod and the existing orientation, that little angle opens up to match what we had on the x-ray. Remembering to move the cast in the appropriate direction so that the apex of the implant moves the direction you want it to move in. So what we do now is, having made the reangulation, we gut this thing out and we'll just surround that with triad gel. This takes all of about 6 minutes in the lab. Surround it with triad gel, in the new orientation and then just cure it with a handheld light curing unit that's back in the lab. Take your pliers and twist out the drill blank and then replace the little 10 millimeter long drill blank back in here. Go back and take another picture. So when I take my second picture, here was the first one that we wanted to re-angle. We did the re-angling. Here's the second picture. So now my drill is superimposed perfectly on top of the silhouette, and I've got a better orientation between the two roots of the teeth. So if one does take an x-ray and needs to re-angle before they make their surgical guides a little bit, you can do the re-angling back in the lab in less than 10 minutes and come on back and take another picture of your patient. Don't send them home and then have them back. This can all be done very quickly. So now that we've basically got the orientation of this correct in our surveyor, we can go ahead and make our surgical guides. If we want a ridge crest preparation guide, it's not very often, but once in a while, if a tooth is extracted, and let's say the tooth had lost part of its clinical crown. So before the tooth was extracted, it had lost part of its clinical crown, so the tooth had extruded. Anybody ever worked on a patient that's had an extruded tooth? It's broken down or tilted. So if a tooth extrudes, can you see it's going to take the bone with it? The alveolus usually comes with it. So now in this situation, if we went ahead and extracted that tooth, the bone would actually be slightly higher than we would like it ideally. So if we didn't do any modification of the crest of the ridge at all, and just drilled our hole and put our implant in and came along and did our crown, the free gingival margins as they went along here wouldn't necessarily be even. So if we want to make a ridge crest preparation, one of the other things we look at is to make a little blank and have the buccal aspect of this be the same exact height as the free gingival margin on either side. Because we're telling ourselves in our mind that this contour I've got right here is where I'd like the free gum margin on my final crown. So when the restoration's all done and the crown's put in place, this is where I'd like the gums to be on that. So from your perio courses that you have, and they talk about biologic width, and Dennis Tarnow did a bunch of stuff, can anybody remember at whatever level the bone is, so wherever the level of the bone is, how much taller than the bone does the gums usually grow? 2 to 3, usually closer to 3. So what you want to do is, if we know before we ever drill a hole, if we contour the crest of the ridge so that it's 3 millimeters below this little curvature that we've made, put the implant in, later on come back and restore it, it's just going to happen that when the gums come back, they're going to be right exactly at that height. Now, if there was some bone loss around the tooth was lost, there were some periodontal problems, and so the contour of the bone is lower than this anyway. So the bone is somewhat lower. There's not a lot you can do about that, and you're just trying to get the best gum margin that you can. So these things work out the best if you think, if anything, the bone's as high or higher than you need it to be, and how much do you need to recontour the bone. And again, we just try to make that little guide so it's consistent with the free gum margin on either side. So at the time the surgeon was doing the surgery, what they would do is lay their flap. They would go ahead and try this little ridge crest preparation guide in, and they would see, is the distance from the underside of this to the bone about 3 millimeters. If it's more than 3 millimeters, there's not much they can do about that. The gums won't be too high. If there's less than 3 millimeters, they'll take a surgical burr and they'll just recontour the crest of the ridge just a little bit prior to drilling their holes to do their implants. So the whole idea around that is what's usually going to happen is wherever the height of your bone is, so when you determine what the level of your bone is, the gums are going to come up about 3 millimeters taller than your bone. So that's the amount that they would recontour the crest of the ridge. So now we make our surgical guide, so we do some block out like we've done before. We take it to the drill press on our surveyor table. We go through our various sizes of drills. And again, for the size implant we're putting in there, those would be the sizes you use. It's dependent on the system. We line things up to make sure we're oriented okay. And then we're going to go ahead and make our surgical guide. Now when we make our surgical guides, remember the thing that we want to do is make sure that the surgical guide intimately fits the lingual 180 degrees of the drill blank, but it's free and open to the buccal. There are many different kinds of surgical guides that are made, and some of the computer programs, Implant, Materialise, some other ones, make a little tube, a stainless steel or a titanium tube that the drill can go right down in, and they're made by computer graphics from a company. So if you want one of those done, you need to have a CT scan done on the patient, which is going to cost, depending on where the CT scan is done, $450 to $1,000. And then typically the cost of making the computer-generated surgical guide is going to be $400 to $800. So there are lots of indications where you're placing multiple implants that I think these kinds of surgical guides are very helpful. If you're placing 1 to 3 implants, I think a lot of times the kind of surgical guides we're showing you right here can be very helpful and give you real good results. So again, you're looking unlike your X-ray guide, which completely surround the little 10 millimeter dowel. When we're sure that our angulation is just where we want it, basically all of the surgical guides surround the lingual 180 degrees of the drill blank. They're open to the buccal, but basically when the drill blank is placed in this recess and you go to wiggle it top and bottom, it doesn't wiggle at all. It really freezes the orientation of the surgical drill mesiodistally. Works real well. And so then we go ahead and just make our sequence. So if we've got an X-ray guide and a Ridgecrest prep guide, 222835, we're all done with this by the time we go ahead and get ready for surgery. What I'll do a lot of times is when I make the X-ray guide, the outer edge at the buccal of the X-ray guide, I make that little curvature we talked about for the Ridgecrest prep guide. So these two are combined into one. All you need to do to make your X-ray guide be a Ridgecrest prep guide is on the buccal aspect of where you're going to place your implant is just have a little bit of a curvature that comes down from that on the buccal that matches the free gingival margin of the teeth on either side of where you're putting it in. So now we go ahead and go to surgery. So they lay their flap. They go ahead and use your drill guide to place their drill. What they'll usually do is each one of these drill sizes will have a little measuring stick. So there's a smooth-sided titanium measuring stick. So when they've drilled their 2.2 hole, they'll slide a 2.2 measuring stick down that and then take a radiograph right away. The reason that they do that is this is the smallest size of a drill they're going to use. So if they found from that X-ray that their angulation was in fact off a bit, despite all your best efforts, if it was off, they could re-angle. So what they always do is at the time they get at this place, they go take a radiograph, and you can see our radiograph is pretty much splits the difference about as good as you can between the two roots of the teeth. So this is the 2.2 drill that's done that. We finish the case up, put in the implant, come back 4 months later, take a PVS impression, pour the model up so we've got the rubber gums on the model. And here's our model with an analog on it. We go ahead and make a porcelain fused to metal crown. We try the porcelain fused to metal crown in the mouth, go ahead and cement it. The reason I did this shot was to show that even from the buccal lingual placement, the consistency of the buccal corridor for our patient is the buccal surface of this tooth lines right up with the other teeth without having an over-contouring down here at the cervical. And as I say, if you get your implant put in the right place, the real payoff on the whole thing is when you let things heal up for a while, the soft tissue just happens. Now, they all don't necessarily come out that pretty if you've got a patient that's got some periodontal involvement. So here we have a young lady, like I say, a dental student's wife. They live out in Seattle, I want to say now. They moved out there. But pretty good occlusion, and these papilla get even better. So where you see the papilla is pretty knife edge on the anterior aspect of our crown, just a little teeny bit blunted. If they'd been around longer, if you see this at 24 or 36 months, that papilla back there will finish being just as knife edge as this one will. So if you're just casually looking in the mouth, you can't pick out which tooth is the implant crown. So with the system you happen to use here, basically, you've got 3 different sizes of abutments in terms of how tall they are. The one we use most of the time is basically what you say the regular neck, regular size, 4 millimeters tall. They make a 5.5 millimeter tall and a 7. They don't routinely stock the 7 here. We've got the 4 and the 5.5. And then in the wide neck implant, they have a 4 and a 5.5. So you don't have an infinite choice of abutments, but you've got all that you need, trust me. Those work very well for you. When you go to take the impression in the mouth, again with this system, you've got this little white basket that there's an insert that goes in depending on which size of an implant you're using. So what you want to do is, here's an implant set up for the 4 millimeter tall implant, and here's one for the 5.5. They're color coded. So the implant for the 4 millimeter tall regular neck, the little abutment that you screw in is gold in color, so all these components are yellow. The 5.5 millimeter abutment that you screw in is just a silver or gray in color, so all these components are gray. The 7 happens to be blue in color, and all of its components are blue. And so what we've got here is when the abutment is screwed into the implant, you take off your healing screw. So when your healing screw comes off, you see this nice little cylinder of healed gingiva that goes down to the head of your implant. You go ahead and you screw your abutment in and torque it to 35 Newton centimeters. Now when you go ahead and screw in your abutment, it doesn't matter, but because of thread timing, you don't know which direction that flat face is going to face. So that's an anti-rotation thing. So if you do a single crown on this abutment, if it was perfectly cylindrical, with no flat spots, can you see the crown could have the possibility of rotating on the abutment? So they put a flat spot on the abutment as an anti-rotation device for the single crown. And so then you've got this basket mechanism. So the basket's what we usually do when you're taking impression is this little white impression basket. Always orient the tabs on this impression basket so that they face buccolingually. If you're thinking of the faces of a clock, straight toward the buckle is 12 o'clock, straight toward the paddle is 6 o'clock. So the tabs on this little white basket are always facing buccolingually, or noon and 6 o'clock. So the company's literature, the literature from the company when you're taking impressions, they suggest that you first snap the basket over this and then place the insert so that the little yellow insert that goes on this lines up. Dr. Billy that used to teach here and left, he came up with the idea about, okay, you know that you want the tabs on your outer basket to point buccolingually. So just note in your mind's eye, just say, okay, which direction did the flat of the abutment face when it was fully tightened down? In this case, it happened to be facing at 12 o'clock. So what if we just pre-assemble the little yellow insert into this basket so that the little yellow insert is oriented with the flat part facing toward the buckle, and it makes it much easier to snap the basket on. It just goes a lot easier. So here's your little plastic insert. Now there's a little tab that sticks taller on the top of the insert, and that little tab is always oriented with the flat spot. So if you're wondering on the inside of this, which direction is the flat, it's where the little tab stands taller. And then this is one of the analogs that would snap into your impression after you've taken it. So here's the outer basket and the insert. So the outer basket snaps over the edge of the head of the implant, which is represented by this 45-degree angle at the bottom of the analog. And then the insert with the little tab indicating where the flat is, that snaps over and picks up the orientation of this top part when it's screwed in place. So what your analog is representing is this is the abutment that would be screwed in, and right here would be the abutment implant interface, and the 45-degree angle there would be the head of the implant itself. So this little basket snaps just past this 45-degree angle, and then the insert will go in, and it's free to spin any way you want it so that this little tab matches up with whatever direction that flat surface faces. Now for the sake of, I didn't take another picture of this thing. For the sake of this pickup impression, what we would do is instead of this tab facing toward the mesial, this little tab should be around at 12 o'clock. So the tab would be in the same orientation where the flat of that abutment is, knowing that you want to always have the tabs on the basket facing buccolingually. Why do they have to face buccolingually, do you say? Can people see what would happen if you put this thing in so that these were facing mesiodistally? You'd bang into the marginal ridges of the teeth on either side. So it's fairly self-evident that most of the time it just doesn't work that well to try to put this little outer white basket in with the tabs oriented any other way than 12 o'clock and 6 o'clock or buccolingually. So knowing that you're going to put the basket in with the tabs facing buccolingually, then relative to that axis, what direction does the flat face? So we would just pre-assemble our little yellow insert with the flat facing at 12 o'clock. Then when we snap the whole thing on, it snaps to place very easily. Take a PVS impression. You take the PVS impression out, and this is what you see. You've basically got the basket around the outside, and you can see the flat of that insert is faced toward the buccal, which is the same orientation that the flat of the actual abutment has. So we go ahead, we can send that off to the lab, or we can pour that up ourselves. Now when it comes to making a temporary for the patient, and the reason we need to make a temporary for the patient is that if we didn't put some sort of a temporary on this and sent the patient off for 2 weeks while the crown was being made, when you had the patient back to seat the crown, where do you suppose these gums would be? They'd be crawled halfway up your abutment, and they'd be tighter than the dickens to your abutment. And that's happened to some of you. So what you wind up doing then is getting a tissue punch or getting your friendly neighborhood periodontist to come on over and help you both anesthetize and cut the dickens out of the gums and cut them back out of the way. So that the gums don't collapse up over the top of your abutment, you want to go ahead and make some sort of a provisional. So what you can do is just take your analog, hollow out the inside of a denture tooth, or take a polycarbonate crown form, or ahead of time you can make a plastic tooth, ream the inside of the tooth out, and then you can go ahead and just orient it on your abutment in the mouth and then finish it up on your analog by painting the margins in. So you just paint your margins in on the analog and polish it. So that's your temporary, all polished. It goes on the tooth, and so your tooth will do just fine. So here's a situation from the study that this person didn't have the most stunning of gums, and so they had a little bit of bone loss in this area. So the mesial buccal of that bicuspid, which this was already done. This was nothing to do with our implant. But you see there's a little bit of the papilla not coming in here quite as much as we would like until later on. So we go ahead, and here's our impression, here's our abutment, here's our temporary. Temporary's in place, a little bit of an open contact there. If we were being real fussy, we'd paint some more acrylic on and close that up. Now here's the crown. We're ready to put the crown in. Now because our provisional fit down nicely around the margins of our abutment in place, you can see that the sulcus is out of our way. You can see the edge of the implant right down there. So that's where the margin of your crown's going to go. And again, this appointment is a whole lot more trouble if you don't make a good provisional. Because what's going to happen here is you're going to be looking down in this sulcus, and it's going to be full of blood and other stuff, so it's not that much fun to deal with. And so making a good provisional makes it possible to have this nice epithelialized socket. Here's our crown when it's all done. We get the crown in the mouth. Again, this is our implant crown, not this one. So this is our implant crown at placement. Here we are with our implant crown. Radiograph and things centered pretty well. Again, we do our planning so things are centered up nicely. So 6 months post-operatively, we can see the gingiva is coming down here better. We didn't quite get as much gingival coverage on this crown that was already there, but the mesial is coming in pretty good. And so we're going to go ahead and look at 12 months. Again, at 12 months, you get a pretty good gum coming down there. And at radiographs, here we are at 2 years. And so 2 years post-placement, you can see we got a pretty good papilla here. We got a pretty good papilla here, and where you see that little bit of a metal collar, that was due to the pre-existing crown where they had placed their metal collar on the PFM crown. But this is our implant crown, so we can see we got pretty healthy gums around here. The level of the free gingival margin is pretty consistent with the adjacent teeth, and we've got pretty knife-edge papilla on either side of it.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.